Welcome to another Phia Group webinar. My name is Adam Russo. I'm excited to be here today. A lot's been going on over the past couple weeks. I can't imagine you guys know what I'm talking about. So it looks like our numbers are even higher than normal because no one's allowed to go outside. So it's great. Our numbers are up. We appreciate it. Today's webinar is we focus on the top 10 of 2020. There's a lot of stuff we're going to go over. You'll notice that we're not just going to talk about the top 10. It's almost we're going to talk about the top 1 of the issues that are going on in our country right now. Folks, we're going to talk about the future. We're going to talk about, what is that, Brady?
COVID.
What is that? Anybody know what that is?
Sure, I've not heard of that.
COVID-19. I haven't heard that yet. Have you guys heard of this?
I think the CO might be for Corona.
I don't know. It might be Corona. Yeah, how does that? That's another issue. Okay? Somebody went to a bar recently and asked for the virus beer. Anyways, we're going to have Jen McCormick present the PGC FAQs, which you love, the political update, brought to you by Brady Bizzarro. And finally, if we get to it, the top 10 of 2020. We appreciate all of you coming on board today. We're already getting questions. Yes, you can get a copy of the presentation. We're going to print it up, put it in an envelope, put a bunch of stamps on it, and we're going to mail it to you. Right?
Perfect.
Is that how we do it?
It's very efficient.
You guys hear that voice? The man to my left. Jen, you coughing?
No.
You cover your mouth. The man to my left is John Jablon.
Hello.
John Jablon is here, replacing Ron Peck, who is, what's the word I'm supposed to use? He's
Self-quarantine.
Self-quarantined?
Mm-hmm.
I'm joking. He's not. He is not here, though. He is visiting a client today. Let's hope he makes it back safe and sound. As always, the man, the legend, Brady Bizzarro. Say hello, Brady.
Hello, Brady.
John Jablon, can you say hello?
Hello. John.
Thank you. And last but not least, the amazing Jennifer M. McCormick. Say hello, Jennifer.
Hello.
Hello. Perfect. Now with that, what motivates us other than trying to make sure we don't get sick? Healthcare costs too much. What do we try to do? Make health benefits affordable. And why do we do it? Why do we do it, Jen?
Because hardworking Americans deserve access to affordable care.
What if they're not American? Why do we have the word American on there? So it's a pretty surprised. Anyways, I'm only kidding. It's important that all hardworking Americans have access to high-quality care. Folks, we're getting a little closer. It's not actually where that red line is, but if there was ever a time, right now when the stock market's crashing, no one has any money, probably the best time to ask for money, huh? So that brings up to contracts. I want to make sure we talk about this. I don't know how to say this word. I'm embarrassed to say it because I've never had to use this provision before in a contract. When we get to the COVID-19, is it force
Majeure.
majeure? Oh, Mr. Jablon, you would have answered that. How do you say that?
Oh, majeure.
It's majeure.
Majeure.
Force majeure. For the first time in my 20-year history as an attorney, I have used that phrase in an actual letter today. So we're going to get into that. So, folks, obviously, whatever you can do, go to ripmedicaldebt.org. Every dollar abolishes how much again? How much is it? $100. Every dollar you donate abolishes $100. Pretty impressive. Folks, follow us on LinkedIn. How many followers do we have now, Mr. Matt?
4,395.
4,395. When he started working here, we had over 10,000 followers. 4,395. Great job, Matt. As always, this is important. You will want to download our podcast after you hear what Brady's going to. Actually, I'm going to say it. Not you, Brady.
Sure.
All that big news should come from me, right? The chief. Listen on Apple Podcasts or Google Podcasts. Feel free to go to our website. You'll see them right there to listen to our past ones. It's important that you download them. And for those who have been, thank you very much for listening. PACE certification. We now know for a fact over 75% of PACE certified TPAs are reported that the tools provided in the certification program on the software have increased their PACE plan adoption rate. Why is it important to you? You have better employees who know more about self-funding, know more about the risks, the fiduciary transfer, and most importantly, have a new service offering for your groups to obtain. This person's a rock star. I know she's there, I hope. Is that her on a, what is that? What is that
Right.
thing?
Donkey.
She's riding a donkey?
An actual picture, yeah.
Oh, Joni, poor girl. Joni Verinder, the compliance director at GPA. So folks that don't know, GPA is one of our longest lasting clients. They've been with us forever. They were with me when I was in my 20s, not that long ago, when Jen was in her preteens.
That's right.
And Joni has been a friend of ours for almost 20 years. She's a wonderful person. She just dialed in, be a friend. That's perfect. And we love you, Joni. You know that. And she told us she once rode a donkey dressed as Mary in a Christmas parade, received a Master of Arts in Religious Education, and my extremely guilty pleasure is watching The Good Place and Lucifer on Netflix. I've never watched either show. Anybody?
Oh, The Good Place is good.
Is it good? I need a new show to watch. I watch every coronavirus, every virus movie, show, Contagion.
Oh, great one.
I mean, I watched them all over the past couple weeks because, like, I'm fascinated. But The Walking Dead is literally my favorite show. I'm just waiting for all the zombies to start appearing. I'm freaking out. But, Joni, we appreciate you listening. It means a lot to us. Speaking of parades, we just found out today, folks, that in Boston, they celebrated St. Patrick's Day parade, where tens of thousands of drunk people gather to look at floats go by, has been canceled.
First time in over 200 years.
First time in over 200 years. Nothing has ever been able to cancel this event before, even blizzards.
Right.
Nothing. But the event will not go on. However, the mayor told us that all the bars in the area will not have to worry about any downturn in money because all the bars will be packed. Great. So the bars will be packed of people all touching each other, but no parade.
No floats.
Very interesting. So, I guess I'm being told I love Lucifer. Great, that's good to know. Folks, thank you, Joni. You'll be getting a care package. I'm assuming Joni already received all this stuff previously. If not, whatever she has not received, feel free to send her away. Okay, 20th anniversary of Phia, as you all know, we're really excited about it. With that, want to make sure everyone's aware, again, that we're really proud to offer free health care for our employees and the dependents who've been on our plan for over 5 years. This has been awesome. In addition to that is not just free health care to the families, but in order to do so, you have to be educated. You have to follow the workshops. We have a whole game plan of all the things you need to do in order to be, I guess, eligible to have the free benefits. It's my opinion that all of our clients and every one of their plans, when they meet with their employers, they probably should utilize our checklist process on the workshops. Never mind giving free healthcare. Just to explain to them, this is what self-funding is. Here's how we can keep your costs low. Do the following things. I think it makes sense. I think we've got a new service. I just got that out of my head right now. So if you're interested in receiving some information in regards to the type of workshops that we do here at Phia, I'd be glad to share that information with anyone that wants it. Now, okay, I think the map, Brady, is wrong, by the way. I think we have to add a couple states here, right? I think that's true.
An hour ago. It's literally updating every hour.
So, folks, before Brady gets into all the details, by far, PGC referral has been inundated with questions on this. And it was funny because John said, what are they asking? Basically everything. Where do you get test kits? Should we make them available for free for our employees? Do we force our employees to be tested?
What can I ask my employees?
What can I ask them? What is the process in regards to sending employees home? Brady and Ron Peck and Brady have been the leaders here at Phia in regards to our messaging to our employees. They've done a great job. Just like all of you, we've had the rumors going through. We've had panic. We've had people that have someone that may be exposed or may not be exposed, etc. So all this is starting to touch a lot of people personally. I said the word touch. I probably should have said touch, huh? But regardless, if you want that assistance, we're here to help you. One of the things that we're seeing is a lot of people are now asking about conferences and so forth. We have definitely seen the number of companies that have done self-imposed travel bans that are either indefinite or have gone through a certain period of time. Yet we're also noticing that there are many conferences, such as SIA next week, that are still going forward. We have yet to make a decision on our conference, which is in June. However, based on all the other conferences that are coming up and based on the criteria, etc., we expect to make a decision on that by within 2 weeks at the latest. As it relates to our Phia Forum, which is going to be in Cleveland, I think June 4th, 5th, and 6th, around those dates. So, the other thing I want to bring up before Brady does his thing is, the biggest area we've noticed is, can I delay a contract? And a good example, we had a client yesterday who has an employer group. That employer group happens to be a private school, a large private preparatory school. That school is starting a fundraising drive, an endowment drive, let's say. That drive was supposed to start yesterday. So what happens? That they contact their TPA, I don't know, not the TPA, the broker, and the broker says, hey, about this COVID-19. What can they do? In every contract, not every, I don't want to say every, let's put every with an asterisk. In most contracts, way in the back, right next to the severability clause, like the provision that no one reads. Should I say that? Or can I not say that?
Yeah, you can say it's true.
It's true, but true, right?
True.
There is what's the name of the provision?
Force majeure.
The force majeure. In that provision, I don't have it in front of me. I'm going to get a copy while Brady's talking, and we'll read it. But technically, in our opinion, based on a typical provision, you probably can get out of implementing, starting, revoking, canceling certain types of contracts based on that provision itself. As Brady starts talking, I'll find it for you.
Yeah, thanks, Adam. So, yeah, I mean, this is really the number one issue we've been getting in our inbox lately, as you probably won't be surprised by. It's all over the news. I tried to give an updated map here of what's going on in terms of the outbreak. But look, this is obviously a very fluid situation. This is going to be with us for a number of months. It has a direct impact on employers, on benefit plans. As the number of tests go up, as tests become more available, and the number of cases go up, this is going to impact more and more of you guys, of TPAs, of your self-funded plans, brokers, carriers. Everyone in the industry will be impacted. And like Adam mentioned, there's tons of stuff out there already in terms of information from other law firms and various sources. But just keep in mind that for the self-funded industry, most of what you see out there is not really targeted at you.
Right.
So
it's not. It's targeted to the carriers, or assuming that people have, hey, you have Blue Cross or you have Aetna.
Fully insured plans that are affected by state law. So these, for ERISA governed plans, you're not going to get all the information that you need.
So this is important here that he's bringing this up, because how it does relate to us and the question we're getting tied to the plan document.
Right.
Brady will give you details, the employee handbook, and then obviously healthcare issues, surprise medical bills, etc. So Brady, you want to talk about some of those pieces?
Yeah, and just a quick note here, and we're going to go into more detail on this many more times in the future, including on podcasts. But from a high level, what we're looking at here under the plan doc is you want to make sure, one, do you cover the kind of test that would encompass coronavirus testing, right? For lab tests, do you have cost sharing? Do you impose cost sharing for that? We get asked questions all the time now about whether, if you have a high deductible health plan, for example, can you or should you waive any co-insurance that may apply for the coronavirus testing? How would that impact a high deductible health plan, and what tax implications? There's no guidance yet, I think, from the government on how they'll consider, if you waive the copay, what impact that'll have. We've reached out, and we know other clients of ours have reached out as well to get guidance on that. But for now, it does appear like the coronavirus test would not be considered a preventive service because it's for the diagnosis of a treatment. So
right, but again,
that could change.
Right, we're already noticing.
We'll still weigh on this by the end of this week.
Right, they're already. For example, the state of Massachusetts already said that you will not apply out-of-pocket expenses, etc.
Yeah.
For fully insured plans.
Right.
Again,
because ERISA will preempt those state laws, but you've seen New York, Massachusetts, California, other states have come out and said you must cover the test, no cost sharing.
But also another thing, just from a realistic standpoint, as an employer, as a CEO here, you might want to pay for the test.
Sure.
Yeah. I mean, and that ties into a lot of the employee handbook issues that we're being asked a lot of, is paid time off. And as an example, an employee has no more days off. They have no sick time. They have no vacation time. So therefore, most people live paycheck to paycheck. So guess what they want to do? Come to work to make money. It's another question we're getting. Should we or can we pay people to not come to work and not work because they're actually sick if they have no paid time off?
Right, and a couple points on that. That's obviously something you hear in the news now too, with the government considering some kind of a package deal in Congress to help those employees that may live check to check, because obviously you don't want them choosing between coming to work sick and having a paycheck. Also, they're floating the idea of a payroll tax cut. We'll see if that gets actually any movement. But with respect to the plan doc, just to finish up here, going through the provisions, what are important provisions? Well, they're your continuation of coverage provisions. Do you have adequate language that provides for a situation where you may have an employee who is self-quarantined or ordered to be quarantined or is just sick and they're afraid to come to work? How is your actively at work definition worded? Is it worded in a way that would cover this kind of scenario, or is it not worded sufficiently such that you might have stop loss issues? That's what you've got to be concerned about. Also look for, you might have certain exclusions in your plan doc that could apply if a state of emergency is declared or if a hazardous area is declared. Obviously many states have declared states of emergency. You might have language in your plan that would implicate claims incurred under those scenarios. So look for those. The employee handbook, very similar, right? You're looking
hold on a second. Hazardous activity.
Yeah.
exclusions. Just throwing it out there. Just thought of it because
right?
you mentioned, well, not even that, like traveling to a place that's declared an emergency, even a state.
Correct.
There's a lot of things. Again, we know that not all stop-loss carriers, there's a lot of really good ones, but they do have some shady characters out there.
Right.
If they can use a hazardous activity exclusion, say, hey, this person got sick, they should not have been there. They should have known better, et cetera. Cruise ships, you mentioned that. Somebody did, right? Great time to take a cruise, though. 3 people on the thing. If you have the whole boat to yourself.
I've actually seen a plan apply that where there's a country with a travel ban.
Right.
And stop loss said, well, you shouldn't have been there, so.
Yep.
Wow, that's amazing.
And there are links on the CDC website to the State Department to tell you which countries you should avoid traveling to. But yeah, be careful about the language there. In your handbook, a good time to review them if you haven't looked at them in a long time. Do you have adequate language for your leaves of absence? Do you have a sufficient work from home policy that makes sense for your employees in the event you need to? Do you have implemented a disaster recovery plan or a business continuity plan?
If you haven't put together, and I'm talking to every person dialing it, if you do not have a business continuity plan or a disaster recovery plan, get one in place now. Now, I'm going to share some information. Brady might not be happy with me on this. However, we'd be more than glad to share, if need be. We have some samples. We've sent out emails to our staff in regards to, just a statement from the organization, from our company, right, as to what we're doing, what we're trying to do, what they should do, what they need to be aware of. We're also, I believe, by tomorrow, Brady, an email will be going out to the industry as it relates to a lot of the resources that are available. We've seen a lot of great stuff out there when it comes to notices, but a lot of it's jumbled. So if you look at 20, 30 different emails to get all the information, we're trying to all put that all into one. We're going to gladly share that with the industry as a whole. So obviously, if you are on this webinar, that means we have your email address, correct? Therefore, you'll be receiving that email from us once we have it.
Yeah.
But I want to make sure we get it, Brady.
One last thing here on healthcare issues. So people have asked us about HIPAA. Does it apply still? The answer is yes. COVID-19 does not trump HIPAA rules, but they've asked about, what to do if they get reached out to by the government asking for information about someone who may be suspected. We can help you answer those questions, but just know in general, HIPAA doesn't go away. HIPAA itself has provisions.
You can't go out there and proactively say, hey, Joey over there sitting in that cube, we sent him home because he's got COVID-19.
Right. There's language in HIPAA which provides for this kind of situation where you have a pandemic. So be aware of that, and also review. Be concerned also about surprise medical bills. A few stories are out there of patients who have gone to hospitals to get COVID-19 testing, but had a bunch of other tests done as well out of network, and they get slapped with a big surprise bill. So be aware of the panic among your staff, and understand that you might have people who run into problems with getting these surprise bills if they go out and get all these tests done that maybe they didn't need to get. Be careful of that. And finally, one important point too. Check your insurance coverages. There are some employers out there who are able to purchase what's called business interruption insurance. We
have that, right?
Mm-hmm.
Yeah, I think we do. You check also that you have employer liability insurance in case someone comes to your office and infects your staff or vice versa. It's a good time to review all those policies. Workers' comp, those are all good things to review at this time going forward. But this is fluid. It's developing.
So one thing I want to add on that force majeure piece. So this is an example of the language, so you guys can listen to this, and then our attorneys here, we got three of you, right? There's 4 of us. Here's what a typical one says. Neither party shall be liable nor deemed to be in default for any delay or failure in performance of any of its obligations under this agreement, whatever agreement that is, to the extent and for such periods of time as such delay or failure to perform results directly or indirectly from any act of God or man-made disaster or any similar cause beyond the reasonable control of either party. If this doesn't fit that, I don't know what does. Reasonable control of either party. Most contracts have this provision. So, again, if you have a conference coming up, if you have a broker convention, whatever it might be, and you put a deposit, and you're worried that it's too late to refund the deposit, these are the kinds of things you can look for in an argument to ask for your money back. Or if you're planning on implementation and your implementation is delayed, don't rely on this section. I would argue that you should write an email or contact whoever it is you're working with and state, FYI, due to what's going on, we are asking for delayed implementation. Here's our clause. So,
and real quick, someone asked us, do we know what the tests cost? I'm not sure we had that information yet. I know that 1 million tests were delivered nationwide. So the truth is, there's not been much testing.
I think there's one on Amazon for like $1 billion.
Yeah, I'm sure there is. That's been a source of contention, but I'm sure we will become aware soon of what the tests cost, generally speaking. I'm sure they won't be terribly expensive, but as I'll talk about in a few slides down the road, this is a time where we're leading people to call for Medicare for all because they want the test made free for everyone. So some people are using this, as a political weapon.
Are you kidding me?
We'll get there in a few slides.
Folks, here's the thing we have to talk about.
Yeah.
Tomorrow, we will do a podcast on COVID-19 employer and plan responses. Jen McCormick and Brady will be handling it. I, unfortunately, have a client coming in. I actually have to work during the day. I can't just have podcasts and fun times. So our plan is, it is not live. Our podcast is not live, but we will post it by noon the following day. I got Matt to agree to that. We also got Pat Santos, our wonderful producer, to agree to it. So therefore, please download, listen to us on Apple Podcasts or on Google Podcasts. It's really fun. If you think our webinars are good, trust me, the podcasts are even better. Okay, with that, go to the next slide.
All right.
Yes, this the FAQs?
I know, I need to change the subject.
Okay, we are changing the subject. We are not going to talk about COVID-19 anymore until 2:01.
It's 5 minutes, yeah.
Until 2 o'clock. Go ahead.
All right, here's a couple of really important questions. Does a plan have to cover a newborn baby under the Newborns and Mothers Health Protection Act if the newborn is not added to the policy? This is a tricky question, and keep in mind here that we are talking about private, self-funded ERISA plans. And a self-funded plan never is going to have to cover anyone who isn't otherwise enrolled in the particular plan. However, when you're talking about the Newborns and Mothers Health Protection Act, there are things to keep in mind. There are particular requirements when it comes to the mother's stay that must be covered under the plan based on the type of delivery or how the baby is born. There are certain you need to stay in the hospital. There are oftentimes plans that otherwise would say that the care for the newborn would be covered under the mother's care, but a plan doesn't otherwise have to cover somebody if they are not properly enrolled. Our suggestion when it comes to this particular question is take a look at your birth or dependent enrollment, automatic enrollment, whatever phrasing is used in the particular plan, and see whether or not this is actually addressed. I would suggest that you actually address that one way or the other. Is or isn't the baby enrolled? And do you need to make affirmative elections about whether that individual, whether the mom or the spouse, the father, needs to cover that baby under the plan by making an election, or it's automatic? Question number 2.
And you know what I just thought about this? Thinking about this question, think about how many babies are going to be born 9 months from now when everyone's quarantined at home. They're going to have a baby. That's going to be the baby boom that we need, right? That's what for those of you who don't know, in Boston, we once in a while have snowstorms. And it's funny, they said the blizzard of 1978, our big blizzard, that 9 months later was the biggest number of births, was 9 months after. So it'll be interesting if we look at 9 months from now, what happens. Anyways, go ahead.
Next question. Can a retired or rehired former employee be treated as a new employee for purposes of our coverage under ACA? So I love talking about the employer mandate.
Oh, we know you do. We know it,
ACA regulations. And this is just something to keep in mind. The employer mandate is still in effect. It is still a requirement. And there are certain rules when it comes to rehired employees and how they are to be treated. There is something called the break-in-service rules. And under the break-in-service rules, if there is an employee who is not working, has been terminated, there's a separation from the job for at least 13 weeks, which, as you know, math is my strong suit. 13 weeks equals 91 days, right? So if someone has not been at work for 91 days or 13 weeks, then you are allowed to treat them as a new hire and subject them to a new waiting period. But if they have not been out of work or they have not been working for the employer, terminated, laid off, whatever the situation is, for those 13 weeks, when they come back, as long as it's within that 13 weeks, you cannot add a new waiting period. There are certain exceptions like the parity rule here that we won't necessarily get into, but keep in mind 13 weeks or 26 weeks if you are an educational institution. You cannot impose a new service waiting period.
Well, none of the educational institutions are even open.
That's true. But
Harvard shut down today.
Everyone's working from home, right? Or getting lectured from home.
Not us. All right. Thanks, Jen. Time for a political
update.
If you could believe, it's time
You're
for
welcome.
another political update. I found this great photo. It looks like it's really old of the Supreme Court, but once again, the Supreme Court is going to be in the spotlight here. We're talking about the ACA and another threat, true, the same threat.
Obamacare again?
Again, here we go again.
Wow.
I believe it's still, like Jen said,
like a
still
rash.
in effect. And I want to point out here,
It's like herpes.
there's a funny irony that the administration, which is fighting this law in court to kill it, is also relying on it for those plans which are subject to essential health benefits to force them to cover the coronavirus test. So they're both relying on the ACA and fighting it in court. I think it's funny, so I wanted to point that out. But look, March 2nd, a couple of weeks ago now, or maybe it was last week.
No, Mark, yeah, not a couple weeks ago.
The news cycle was really fast for me, Adam. Supreme Court announced that they have finally decided to hear this Texas case that we've been talking about for webinar after webinar. The Texas case that is challenging the entire Affordable Care Act itself. Remember, over a year ago now, a year and a half in fact, when the Republicans passed their tax cut bill, they got rid of the mandate, individual mandates penalty. We know that's been gone for a while now. Because that's been done, a number of states' attorneys general, Republican ones, brought suit in court in Texas, in federal court, arguing that the whole law has to fall now because once you remove this individual mandate, nothing else can stand. It was so important to the case. The Texas judge there agreed, struck down temporarily the ACA, put his ruling on hold. It got appealed to the Fifth Circuit in New Orleans last year, and that court kind of bungled it. They said, we kind of agree, but we don't. They bumped it back down. They basically punted until Supreme Court agreed to hear the case. Now they've agreed to hear the case. That's a big deal. But I want to point out here, this case won't be heard until after the election, of course, right? So it'll be heard.
If there is an election.
If there is, right. It could be canceled, and we could have, another 8 years or whatever it may be. But they're going to hear this case in the fall. Who knows? Who knows how long this will last? So, look, here's the issue. The issue will be, this is the third time the Affordable Care Act's been with the Supreme Court. The Chief Justice has saved the law twice. Will he do it again? The composition of the court is different now. You've got two justices that were appointed by Trump. You have a clear expression from the administration that they want this law gone. Many legal experts, I've said this before, think that the argument's pretty weak that the whole thing has to go, especially when you consider, again, that the administration itself knows.
Nobody cares what other people think.
They only care what I think.
You think, because you are the legal expert.
So let me give you a prediction. My prediction here is that part of the law may get struck down, but that the fundamentals of it will stay in place. That's because they
just like that Phia fleece you're wearing.
Right, which is at this point a little dated, but I'll get a new one.
Folks, Joni, if you don't mind, instead of giving you a Phia fleece, can we give an upgraded fleece
Send it back to me.
Brady? That thing needs to be.
It's kind of like sentimental for me now. Look, I think that's what's going to happen. I think I would not imagine that the Supreme Court's going to toss out the entire Affordable Care Act. I'd be shocked, but put me on the record. We'll see how that plays out. Speaking of played out, let me speed through a few more slides here on the state of. Remember, we have an election going on here. We had Super Tuesday, where it seems to have consolidated the race. It's a two-person race. Today, there are 6 more states in what I'm calling Big Tuesday that are voting. The race could be locked up.
Big Tuesday?
Most people are calling it, yeah. On Twitter, it's a thing. Don't
all 5 people that are following it.
But look, here's why it's important. One candidate is a Medicare for All candidate, the candidate that really threatens our industry as an existence. The other candidate, Joe Biden, is calling for an improvement to the ACA, and it looks like he's steamrolling ahead to victory. We'll see if he wins Michigan tonight. But he cleaned house last week.
Who's projected to win Michigan? I would think
he is.
Should be Biden.
Biden's up by like 10.
Well, Sanders, Medicare for All doesn't really seem to work with the union workers, right?
And a lot of auto workers are in Detroit. The Obama administration saved them.
I can't imagine Sanders wins Florida because of his Cuba
all the old people. Right.
Castro comment.
I agree.
So then Biden's wins.
It doesn't look good for him. But, again, things can change. We never know. But I want our listeners to understand here that they're not out of the water yet. Check out this exit poll that's been done for Super Tuesday states. They said, Democratic voters, do you support replacing your private health insurance, that means us, with a single payer? And every state, Democratic voters said yes. So we talked about this before, and it's still true now. Medicare for All, for like it or not, is in the discussion. It's now something that's not going away. A majority or plurality, at least, of Democratic voters want it. So we have to reckon with this. So it's not like we can all rest assured that, Biden's going to win, Medicare for All is dead forever. Clearly, Democratic voters like it still, according to this exit poll.
Am I crazy to think that by November, right? Let's just assume this is all correct, right? Without having to say Trump or Biden or Trump or Sanders regarding Medicare for All, it would seem to me that the Hospital Association, as well as the Pharmaceutical Associations and whatever trade associations they have, would put on a huge campaign talking about how Medicare for All would literally ruin the hospital systems.
Yeah.
Because we know what they're reimbursed. They're not reimbursed Medicare rate. They're reimbursed something a lot more than Medicare rate. And secondly, the argument can be made that, COVID-19, there won't be what's the word I'm looking for? Not a cure, a vaccine, because no manufacturer is going to be in the business of making new vaccines if they can't make money. So, I'm interested to see if that happens as we get close to Election Day.
I think it will, yeah. I think we're not there yet. I think it will happen. For now, they're just pouring tons of money into the Biden campaign. We'll see, though. The point is you got to worry about Medicare for all still, and you've also got to worry about John Jablon.
Finally, Mr. Jablon is going to get to talk. The number, and this is it. I'm going to tell him to jump on this. The top 10 cost containment measures. The number one is there as number one for a reason, John.
Sure is.
So can we talk about it a little bit? But also, what I really want to know is how many people, what percentage of our plans do you think have the wrong U&C language in them?
Well, it depends what you mean by our plans, because
like our clients, our typical plans that we see.
Well, if we write the plan
before we write them, before we rewrite them,
I would say close to 90.
Really?
Let's say 90%.
90%.
Maybe 95.
That high?
Yes, absolutely.
Really? I would think it's lower than that.
U&C language, well, I should say bad UNC language is a plague worse than COVID-19. There's a clear reason that it's number one on this list is because it doesn't do what you think it does. If you don't have good, strong UNC language, you are in a lot of trouble, and that's with stop loss, which we'll cover in a few numbers. It's not number one, but as well as just the general plan cost containment. Because if you're saying that, for instance, and this is the kind of classic UNC language, that the plan is going to pay what other area providers charge, that language it's just deadly. It's a disaster. Because other area providers, guess what? They're also overcharging. So if your plan is saying that we're going to pay what they charge, well, what they charge is nonsense. So we're saying we're going to pay nonsense. Well, it sounds like nonsense, for lack of a better word, right? So there are a few things to look at when you're looking at UNC. One is discretion. Now, the plan administrator should always have discretion. That's something that we have touted for years. If the plan administrator doesn't have discretion, there are certain legal ramifications of that. That's another story for another day. But you need discretion to determine UNC based on certain factors, because every claim is different, every audit is different, and plans do different things. But if the discretion is something as simple as the plan administrator will determine what UNC is, that doesn't say anything. It doesn't actually tell anybody anything, and it's a mess because if it goes to court, the court's going to say, this plan doesn't tell the claimants, the providers or the patients, how it's actually going to calculate the allowable amounts for claims. So if you don't actually say anything, well, guess what? That's not good language. So that's that first bullet there. And then we move down to some other weird things. And the second and third bullet, relying on other vendors and the black box approach, a lot of the times they go hand in hand, because what we call the black box approach is when you give a claim to a vendor, ? And then the vendor gives you a number. You don't know how the vendor came up with the number. You don't see the calculations. You don't get an explanation. You put the claim in one side of the box, and out the other side it comes with a number. And the plan says, great, thank you, vendor. Plan pays that amount. And then the provider says, hey, why did you pay this amount? And they say, I don't know, our vendor told us to. Big red flag right there. Huge, huge red flag. We've seen tons of claims go to court and, generally ultimately get settled out of court just because it's such a weak case for the plan. But when you use a vendor and they don't tell you how they came up with the language, they don't give you plan language, they don't tell you how they came up with the price, they don't give you plan language to support it, they don't give you arguments to support it, and they don't give you an explanation, you are opening yourself up for a ton of liability, because the claims regulations talk about how you have to do what's in the plan doc. And if the plan document is too vague, you can't actually comply with those regulations. And then the last bullet here, applying to in-network claims. If you have a claim that's in-network and the network doesn't allow you to reprice that claim based on UNC, you should not be repricing that claim based on UNC. Now, that's easy in theory, but bad plan language defines UNC as the lesser of whatever, right? Maybe it's the lesser of what other area providers charge, or the actual billed charges, or a negotiated rate. But if you're paying something less than the negotiated rate because the plan tells you to, you are probably violating the network contract. So be very wary of that. And if your UNC language does not have the strength that it needs based on what I'm describing here, please contact us.
And again, we're talking about one paragraph. One paragraph of wording can be changed where you can literally save hundreds of thousands of dollars on one claim.
Right.
Okay? Yeah. Wait, who's back? I wish you could see Jen McCormick's outfit today. It's very mustard. Mustard is
It's the color of the season, actually.
Mustard's the color of the season? It was when I was in high school. I remember that. Oh, geez.
Man
She
alive.
is fashion forward, as we all say. So, Jen, what are the ACA updates for 2020, and why is it important to have compliant documents for cost containment?
All right, our number 2 on the list of things to be on the lookout for. We're almost there, almost to the top 10. All right, so we're talking about ACA updates. So the first is the ACA out-of-pocket increase for 2020. It has increased from $81.50 for individuals and $16,300 for families. So
What a cop-out.
you know what? This is a 3.1% increase from last year.
Wow, you did that on the fly?
No, I previously did that. But that is important to know that this is specifically for ACA out-of-pocket plans. So we're not talking about the high deductible health plan rules. And when it comes to what counts towards these annual caps, this is only going to apply for your in-network essential health benefits. So if you have non-network or non-essential health benefits, they're not otherwise subject to these annual out-of-pocket maximums. There are separate limits, however, for the high deductible health plans. And this is interesting because over time, these numbers have evolved. The out-of-pocket maximums that are for ACA, those are the ones that are being calculated by HHS. However, when it comes to the high deductible health plan rules, those are being calculated by the IRS. And interestingly, there are different formulas and methodologies that they are using for how they're getting to those amounts. We talked about this earlier about whether it would or whether it wouldn't be okay to waive the deductible when it comes to getting this testing for COVID-19 done. This is why it's important that the IRS is making this determination and not something that is to be addressed under the ACA regulations. Another thing to note here when we're talking about the affordability rules, interestingly, the threshold for when penalties would apply for an employer when it comes to affordability actually decreased in 2020 from what they were in 2019, which is not something that we're commonly seeing when it comes to penalties. The other things to be on the lookout for about contraceptives is there will be more case law. This is going to the Supreme Court. We are going to hear whether or not this is something that you can object to, reject, remove from your plan, exclude from your plan based on your religious beliefs or your moral objections to it. Also, over 2020, there are some new preventive care rules that have come into play, some new screening requirements that plans have to be subject to. And based on whether these are a change from a to a B recommendation, a B to a C, or a D to an A, there are certain rules about when and how these recommendations and screenings need to get added to the plan. And unfortunately, there is no news when it comes to the wellness rules updates. We are still waiting. Hopefully there will be something, but we do have some recommendations in the short time when it comes to what it is that your plan is actually doing for wellness. The first is taking a look at your HRAs. Are you requiring a biometric testing? Maybe you should consider removing that. If you're offering a smoking cessation program, is that something that you are doing and requiring a blood test, or otherwise are you just requiring people to say that they do or do not smoke? The last thing, I'm so sorry, before we move on to the next one, I think this is important. The SBC template, we've been talking about this in 3 years, since 2017, but the time has come. For 2021, there is a new SBC template.
Yes.
New rules, a new calculator, new instructions, and why has this happened? Well, we all know that there's no such thing as the individual mandate anymore, right?
That's right.
Well, when they built this template, there were certain questions that were built in there to address the individual requirement. So they needed to modify the template to address and accommodate that not being applicable. So they added a bunch of not applicables as well as updating the calculator, which I think is going to be important. But a plan isn't required to use the updated calculator. They can still use their own formulated version of HHS one. They can use whatever is going to work best for them, even if creating their own is going to be more accurate than using the HHS one. So that is yet to come, but know that there is going to be a new template in place for 1/1/21 for any coverage that would be effective under that date. So you are going to be required to do a new SBC. That's it.
Wow.
Very exciting stuff. Next, let's talk about some concerns when it comes to being the fiduciary. This is important. This should be number one, not U&C.
Too late.
It is important that you are following the terms and provisions of your plan document. To do so would otherwise be a fiduciary breach. And it is important that when you are looking at your plan document and making decisions and using that discretion, that you're using your discretion in a way that is uniform and consistent. This shouldn't be something where you are making an exception based on someone's particular status or based on someone's particular holding or whether or not that's been a good employee or a bad employee. And remember, when you're making these exceptions to cover something or to exclude something based on your discretion or your interpretation of the plan language, that doesn't automatically mean that it will be subject to being reimbursed for the stop-loss carrier. So when you're having these discussions where there's maybe a gray area or there's something that's left to be interpreted or there's something vague and you're making a decision, that should be something that should be communicated and discussed. And even more on a go-forward basis, this is something that needs to be documented because you need to make sure that you are following this as a new precedent for the new law about how you're handling this particular situation. And maybe that's a really good reason after using that discretion, if there is vague language, to make a modification to your plan in the future. So maybe you should be thinking back over the past year, were there any areas in my plan that were vague? Were there situations that required me to use discretion that I don't know that was clear to our particular participants and maybe we need to clean that up? Is COVID-19 a covered benefit under my plan? Maybe this is a good opportunity to actually modify your plan to address those in the future because the risk of not doing so is going to subject you to fiduciary damages, which are serious. Those are intended to disrupt that behavior, to stop that behavior from happening in the first place. So it's important that you are following your fiduciary obligations under ERISA. And also just a note about consistency between your different documents. I just spent a couple of minutes talking about the SBCs. So when it comes to making those updates, you need to make sure that the document, the SBC, any plan materials that outline the benefits are all consistent and uniform, because that could add to any sort of fiduciary breaches where you're not communicating effectively what benefits are actually relevant for the plan participants to know about. Back to you, John.
Thanks, Jen. All right, number 4, seek help when you need it. This is kind of a general note, not a specific topic like U&C or following the plan doc, but it's important to note that gaps, gaps, are one of the most prevalent things we see that cause problems for our clients. And the traditional gap that we talk about a lot and that we've seen through the years is the plan document and the stop-loss policy. But because there are many more documents involved in the self-funding process, there are many more potential gaps. One that we've seen cropping up more and more, especially with respect to leaves of absence, are gaps between plan documents and employee handbooks. That's, it became such a big issue that we even created a whole service based just upon that. But, when we're talking about things like unwritten internal rules that plans can have, and it's always seemed very strange to me that health plans are allowed to have internal policies that are not in the plan doc, but in fact they are. Make sure that there aren't any gaps between those internal rules and the plan doc, or between those internal rules and stop loss. Basically, no matter what document you're looking at, if they're two different documents, they have the potential to have gaps. And that's even true, and this is terrifying, but it's even true between a plan document and a summary plan description in the event a plan has both. Now, most plans nowadays, as we know, have one document that's the plan document and summary plan description, but some plans are old school. They've got a separate plan doc and summary plan description, and those can differ. And that's a big, big problem because the courts have come out and said that the differences really do matter. Because don't forget who's supposed to be reading these, patients. Patients are reading these, so you need to be clear. You need to make sure that everything says what it's supposed to say. And in the event of conflicts, usually they're going to be read in the patient's favor. Thanks, Brady. Problem. All right, and number 5 on this list, overpayments. Don't let your overpayments go to waste. The best advice I can give here with respect to overpayments, don't worry about fault. Don't think about whose fault it is. It doesn't matter. Try to get them back. If you identify an overpayment, try to get it back. Like I said, it doesn't matter whose fault it is. It doesn't even matter the reason. Obviously, some are going to be easier to recover than others. Some you have arguments for. Some are just kind of, what's essentially making demands to providers, and there isn't a whole lot of law to back it up. But regardless, try to get them back. There's absolutely no harm in trying. The worst a medical provider can say is no. And even then, keep fighting. But do not let your OPs go to waste. It's a very important cost containment tool that so many plans and TPAs overlook. And to be honest, we've actually had TPAs come to us and say, we don't want to try to recover these OPs because we don't want to highlight the fact that we misapplied the plan's U&C or whatever it may be. It doesn't matter. Don't think about fault. Just try to get it back.
In regards to this, I know, Jen, if you want to talk about a little bit, I don't mind. folks, please reach out to me directly, arusso@phiagroup.com, phiagroup.com. We have some new subrogation value reports. It's basically reporting tied to a Tableau that's instantaneously. You'll be able to actually run these reports yourself. We will send over to you sample ones so you can see the type of information available to your actual client plans. It's more than just active cases and recoveries. It's actually in-depth information in regards to how many investigations have you done over a period of time. How many claims are you actually reviewing? So we're talking about you might have 3 active cases, but you've reviewed 2,000 claims, investigated 500 claims. More behind-the-scenes information. It's really important to know, especially now when you have more and more state laws, as well as even federal circuits, that are definitely denting the ERISA shield when it comes to subrogation rights.
Yeah. So talking about Michigan, today, huh?
Yeah.
So this is a new law that has yet to go into effect. This will take place on July 1st. And before we get into this, just know that we have drafted language, subrogation, and coordination of benefits language to address this. So should you have questions or concerns about the impacts about this Michigan law, regardless of whether or not you actually are in Michigan, this is language that anybody can use. We have drafted that. So without further ado, this is a new law that is going to take effect in Michigan, that is essentially going to allow that individuals who now can forego having to have that unlimited personal injury protection, or I think in Michigan they call it personal protection insurance, PPI. Doesn't matter what state, every state has a little bit of a different way of how they are talking about it. So this is going to say that unless you are otherwise covered by some sort of health or accident plan, you can elect to have unlimited coverage or a particular limit on your coverage now. So how is this going to impact our subrogation language? Well, this is going to be an opportunity for maybe an exclusion or other coordination to exist that didn't otherwise exist. Maybe this is putting more benefits and coverage on the plan that didn't otherwise exist. But now you're going to actually have to pay more attention for those individuals who are involved in those car accidents or incidents in Michigan and see whether or not there is going to be other benefits that you can coordinate with and whether to what extent they have made that election, whether they have foregone it or not, when it comes to the PPI or the PIP or no fault or whatever you want to call it in that particular state. So you should be taking a look at your subrogation language and making those updates. And if you have questions about what that language should look like, you can always reach out to us and ask us questions.
I would argue this next one, number 7, probably shouldn't be number 7. I would move this way up as well, specifically because we see a huge uptick in regards to direct contracting, carve-outs, everything from, as this appears, dialysis to hemophilia, et cetera. One of the things I noted, and I want to give kudos to Jen for this. I have a presentation coming up where this organization is having a 10th year anniversary. So I said, wouldn't it be cool to look what a typical plan looked like 10 years ago and compare to what one looks like today? Jen nicely actually gave us a plan that we have been representing for over 10 years. The difference, there's differences everywhere. You'd be surprised with the copay and out-of-pockets, how much they've shot up. But that plan was an EPO. But, $1 million maximums. Now, it's got every type of PPO, RBP, direct cost. It's got everything in it, which did not exist on this particular plan 10 years ago. So sorry to take you a little bit of Jeff Long, but I just wanted to bring that up because it ties into a presentation we're doing.
Yeah, I mean, simply put, not all benefits are created equal, right? The plan doesn't have to pay everything at the same copays, coinsurance. There can be different limits for certain things. I mean, one of the best things about self-funding is that you're able to get creative, and Jen will talk about that a little bit in slide 10, which should probably also be higher. These should all be number 1. These are all number 1 things you need to do, all 10 of them. But dialysis, for instance, hemophilia, specialty drugs, very popular carve-outs. There are some vendors who can help you with these, or, frankly, a carve-out is not necessarily something that you need to use a vendor for. There are certain things that you can just do different things with, and whether it's in the plan or in a separate document.
Employee handbook?
Exactly. A carve-out is just a fancy way of saying this is different from the rest.
Wait, how about a fancy way of saying carve-out?
Yes. Thank you, Adam. Very analytical. I like it.
How's that fancy? How's carve-out a fancy way of saying anything?
I guess it's not very fancy.
Thank you. I'm listening. I listen once in a while, folks.
But yeah, and just one final note here, something that you really need to look out for is if you are doing, for instance, a dialysis carve-out, you can't just find out that somebody has dialysis and then carve it out right then. No.
Is that discrimination?
It just might be.
So is that a fancy word?
There are certain rules about that. If you have any questions about that, feel free to contact us or talk to your vendor, but just know that it's not quite as simple as just doing it whatever. And number 8 here, take a look at your network.
We've made a lot of money for people doing this incorrectly.
Well, yeah. There are certain pros and cons of networks. It's all dependent upon what your values are, what your priorities are. I mean, obviously, PPO networks give you an almost complete lack of noise. Of course, for in-network claims, right, members never need to worry about balanced billing, but at what cost? There's very, very poor cost containment in the typical PPO network. So just things to consider. And then, if we look at wrap networks, it gets way worse. The same restrictions, but worse discounts and more, it can get bad. So,
why don't we just tell everyone to call Phia?
Sure. Number 8, call Phia.
Perfect.
Yeah.
Speaking of which, Brady is interrupting again. Why are you interrupting our top 10?
Well, we have another disruptor getting involved in our space.
Here we go.
So look, we've talked about the Haven initiative with Berkshire Hathaway and Amazon. Walmart wouldn't sit by idly, would they? Of course not. Behind the scenes, Walmart has been doing some very fancy things. This is a new Walmart health clinic that they're debuting in the Georgia area, I think Atlanta, near Atlanta. We'll talk about that in a second. But first here, with respect to networks, Walmart is...
Can we make the font any smaller?
Well, look, I had a lot of information I want to get in here and not much time.
You have the ability to make it another slide.
True. It's true. Well, we
throw it out there.
Here. So look, Walmart's the largest private insurer in the country. There's 155 million Americans with self-funded insurance plans, or employer-sponsored plans, rather. Walmart has 1 million of them. And what they're doing now for their own plan is they're getting rid of their old PPO, and they're building their own narrow network. Their own network that's going to have its own physicians. They're calling it curated network.
They pay these guys.
Who know, probably good money. But it's going to be, they're rolling it out in 2021 in 3 areas, Dallas, Orlando, and Northwest Arkansas. And the idea is they're going to have some really great cost containment approaches to these narrow networks. And it's going to be something that I can bet my bottom dollar that if it works for their plan, they're going to sell to people in our industry.
I don't get why it's here. This ties into number 8, which is talking about the networks.
Exactly. So we're going to watch and see how these develop, how these narrow networks sort of work out. I'm sure they're going to keep the data relatively close, but I'm sure we'll get some wind of how these work. But it's also playing into their plan for nationwide health care. This is perhaps even bigger in terms of...
They don't have enough already.
Right, not enough already. But just real quick here, everyone knows that a lot of retail chains already have health clinics like CVS, where you can get certain basic services done. Walmart has the idea for a much more comprehensive clinic. They're calling it Walmart Health, where patients can go to see doctors for some more advanced treatment for people with chronic conditions and diabetes, heart disease, even without insurance. They're going to have lab work, x-rays, hearing exams, counseling.
They have vision already, right?
They do. They're just adding a lot more here. Look at these prices, though. Annual checkup for an adult, $30 without insurance.
Hold on a second. The copay.
No, that's the full price.
No, but the copay on a typical plan that we represent is higher than the checkup.
Yep. Dental exam, $25. Can you believe that? Therapy sessions for $60.
Do they give you wooden teeth? Like, what is this?
I mean, it's unbelievable the prices that they're going to be able to undercut in the market. But we're going to watch when they roll out these more advanced clinics. They're going to probably be nationwide, and they're really going to disrupt the market. But for some more disruption of our own, I'll turn it back over to John to talk about stop loss issues.
John, be nice to the stop loss carriers. We know how you are sometimes, so be nice. What are we looking for?
I'm always nice.
Nice and easy, John.
All right. What we're looking for is a shorter policy. It's generally better because it means that the carrier is not...
Well, what if we had a policy that says we exclude everything? That's a short policy.
It's a short policy. And it
would not be good.
Thank you, Adam. Thanks for pointing out that logic.
But the biggest thing to look for is what? Is you think your top 3. I'm assuming the right to interpret your own terms.
Sure.
That's a bad one.
Yeah.
Their own definition of...
Yeah, U&C here, this third bullet here. It ties into number 1, and this is, of course, number 1 as well. Take a look at your stop-loss carrier.
Got it.
But if the carrier defines usual and customary differently than the plan, you're always going to have a problem. Because, one thing that we see all the time is this network example here on the bottom. The plan gets a claim for $200,000. The network rate is $180,000. And the plan says, wow, I get a $20,000 discount. $20,000 is a lot of money. Either way, that's what we have to pay, so we pay it. But stop-loss says, well, we did our own review based on our policy language, and we are going to allow $50,000. So that
$50,000 would be the reasonable amount to pay.
Right. So $130,000 is excluded, and the plan says, but hang on, we were contractually required to pay that $180,000
based on the in-network claim.
Exactly. And the carrier says, sorry, I don't know, not our problem.
Right, because then that
because
folks need to know your stop loss carrier is not required to follow the network. They don't have a network agreement.
Right.
So one of the things that I try to tell people sometimes, if you're worried about something like this, there is you could put in an email, have in writing, that if it's an in-network claim, the stop-loss carrier will follow the network rules as they apply to you.
Yeah, and we're seeing some contracts or stop-loss policies rather that say that increasingly, but it totally depends on the carrier. There are some carriers that are willing to work with plans and really understand what the self-funded plans are doing, and then there are some carriers that just value cost containment above all else and kind of do their own thing.
This last one, Jen, I want to make sure we bring up, is that Brady is more than willing to share with folks our checklist of our workshops. In addition, we're more than willing to share some of our incentive language, our incentive programs, et cetera. As you all know, the Diapers and Wipes program, consultation with AR, our predictive, modeling, our direct contracting, all the stuff that we're doing in our own plan design, which allows us to do what we do with our employees and the lowering those costs. That's creative. That's creativity. That, to me, even though it's number 10, in the long haul, it's going to be number 1. This is going to be the way for you to actually have the highest level and potential for true cost containment in your plan design. Anyone want to add to that?
Yeah, I mean, and for our plan, we just talked about how it's totally different now than it was 10 years ago. And all of these things aren't born overnight. Get it? Just kidding. So all of these things.
Don't get it.
Don't get it. Oh.
Diapers and wipes, yeah.
Oh, okay.
Oh, goodness. So you have to take a look at your population. These aren't things that are specifically limited to what the plan can do, but what can you do as an employer? How can you incentivize behavior? Where are your risks? Where is your exposure? And using that opportunity, that's where you can get creative. And the things that are right for Phia may not be right for your plan. So maybe you have a particular situation that you want to talk over and you're looking for an opportunity to build in an employer incentive. Talk to us, because we're here to help design something that is for you.
In order to help, we can help you on our next webinar. April 23rd, 1 o'clock Eastern Time. If we're here, we're doing this webinar no matter what. Guys, if we are quarantined, we'll do it from home. We'll figure out a way. By then, I don't know what will happen to me. If we're around, folks, and hopefully we all are, hopefully you all are as well, April 23rd, 1 o'clock will be our next webinar. On behalf of John Jablon, who did an amazing job filling in for the irreverent Ron Peck, Jen McCormick, our wonderful PGC correspondent, Mr. Brady himself, who, honestly, Brady, you're taking that off. I will fire you if you don't take it off. And myself, your host, Adam Russo. Thank you so much for joining us. I hope you're all well. God bless. Be safe. See you next month.